My friends, let us consider that acuity is the refined clarity of thought and perception which enables one to discern subtle truths.
Hey everyone, and welcome to this week's episode of the Acuity podcast. As always, Acuity is best savored over an indulgent and stimulating caffeinated drink. To me, I like to drink my coffee black. Sometimes I will indulge with a nice sweetened creamer, especially if I'm having a dessert with it too. But you grab your favorite fix, a steaming cup of coffee, a refreshing Diet Coke, a soothing tea, or prepare to get sweaty with a pre-workout. Let me know what you guys like to drink along with this. Are you listening to this mostly at home? Are you listening to it mostly at the gym? I'd love to hear from you. Let's get started. On the agenda this week, we will be discussing the intersection of special interests and healthcare, exploring how this can lead to corruption, influence policy, and affect patient care. And then, as always, I will discuss a specific healthcare topic of concern. This week, separating simple from serious infections. Let's start at the most granular level of how special interests influence prescribers. The example of OxyContin in Canada is particularly notorious. Purdue Pharma, the manufacturer, aggressively marketed OxyContin with claims of lower addiction potential, leading to widespread prescriptions. Physicians, often swayed by marketing, educational grants, relationships with drug reps, or even direct payments for speaking or consulting, played a massive role in the opioid crisis. It's worth noting that esteemed lecturers on pain management echoed pharmaceutical talking points, sometimes taking copyrighted material paid for by Purdue and using it in lectures. Yes, this happened in 2010 at the University of Toronto. Beyond the individual practitioner level, it's worth considering the role that regulators and medical institutions play in this too. There were serious concerns about Purdue's influence on pain management guidelines, where the emphasis on opioid use was disproportionately high. The Canadian guideline for opioids for chronic non-cancer pain was updated in 2017. In 2015, there were almost 20 million opioid prescriptions handed out. So you can imagine how things continued to evolve and worsen up until 2017. As a reminder, it was 2007 that Purdue pled guilty to misbranding OxyContin, claiming it was less addictive. This is not unique to narcotics. Consider the move in statins and cholesterol management, or hypertension guidelines, and the broadening population and softening indications for prescriptions, whether it would come from the Canadian Cardiovascular Society or Hypertension Canada. I don't want to put the blame on any one institution, any one medication, or any one guideline, but it's definitely worthwhile thinking about how big pharma and other industries influence both the local practitioners and their prescribing patterns, as well as experts who then determine guidelines, and then those go on to further influence the individual prescriber's practices. But it gets much worse. Suppose there are two physicians, one who follows the guidelines and one who does their own analysis and then opts for a different route. That may or may not have been the better route as determined over time. Suppose in each case a complaint is issued to their respective regulator, for example, the College of Physicians and Surgeons. Who is better defended? The one who did their own research and may have correctly identified a weakness in the pharmaceutical guidelines, or the one who blindly adhered to a guideline influenced by industry? So you see, the regulators can act as perpetrators of industry influence by forcing individual practitioners to adhere to guidelines despite what their own conscience or their own knowledge might suggest that they should be doing otherwise. I will have a lot more to say about that next week. Let's take one last bigger picture look. Surely a beneficent liberal government is immune to this, right? It's the cronyism and greed of capitalist right-wingers. Sadly, no. There is no government that is immune to these forces, whether it is policies that protect liability for manufacturers, fast-tracking drug reviews, hiding harmful data from off-label use of medications, or price setting for drugs. I want to discuss a notable case involving Dr. Matthew Herder, whose recent controversy with a liberal government over pharmaceutical pricing raised eyebrows. Dr. Herder, a respected figure in health policy and a professor at Dal Law, raised major concerns when he suddenly resigned from the Patent Medicine Price Review Board. That's the PMPRB. It's a mouthful. This board was supposed to advocate for lower drug prices in Canada by informing government on specific recommendations and guidelines and policies that they were making as suggestions. In the 35 years since its inception, none of its original objectives have been achieved. Dr. Herder joined when new guidelines were being drafted under Trudeau. He points out that despite commitments to lower drug prices, the government repeatedly delayed or abandoned the implementation of those guidelines. Further, that the government undermined the PMPRB's independence by succumbing to Big Pharma's lobbying. Not only did the pharmaceutical industry fail to meet its obligations to reinvest in Canadian research and development, but the government failed to enforce those commitments or defend its own pricing policies against industry, challenging them in the court of law. These intersections of special interests and healthcare policy and practice in Canada highlight a systemic issue where transparency and accountability are lacking. The influence on drug pricing, medical guidelines, and prescription practices not only affects the cost of healthcare, but can also determine the quality and safety of patient care. It makes it very difficult, if not impossible, to get injured patients justice. The integrity of healthcare should not be for sale. Next, I want to talk to you about the specific topic of today and how clinicians encounter many minor infections and how they differentiate them between those that are high risk and those that are benign. This requires diligence and attention to detail. I want to begin by highlighting some of the general principles separating serious from minor infections. Minor infections typically present with localized symptoms: redness, swelling, mild pain, manageable often with oral antibiotics or even just symptom control. I should specify here, the vast majority of the conversation is going to be about bacterial infections. Viruses are kind of different in that mild viruses can be quite systemic, causing lots of different symptoms in multiple systems. Serious bacterial infections, however, manifest with systemic signs: higher fevers, severe pain, or even altered mental status. These infections aren't always confined to one area. They can spread, potentially leading to conditions like sepsis and organ failure. The range of infections is really broad, depending on whether they are viral or bacterial, or otherwise, parasites, and so on. Especially if you consider not only the types of infections, but where they are located. Giving a deep dive to each type is not feasible in a podcast like this, but I want to highlight a few classic examples. Let's start with skin infections. A common skin infection is cellulitis. Cellulitis is a superficial skin infection, showing redness, warmth, and tenderness, generally treated with oral antibiotics. Some patients with bad comorbidities may need more than that. But there are other infections of the skin or deeper structures that can hide there too. For example, a necrotizing fasciitis or flesh-eating disease, with rapid spread along the fascial layer just under the skin, which is characterized with pain grossly out of proportion to the skin changes and accompanying systemic signs. Another example would be an infection of the bone or an osteomyelitis, following from trauma or spread from nearby skin infections in susceptible people. It's more insidious, with signs like persistent pain, worsening swelling, and fever, necessitating IV antibiotics, sometimes surgery, and really prolonged treatment and monitoring. Another example would be infections of the throat. Sure, we see a lot of strep throat or simple pharyngitis, sore throat, fever, redness, often managed with fluids, rest, and some basic antibiotics. But there are several much more serious infections that can hide there too, like an abscess, either next to the tonsils, what we call peritonsillar, or at the back of the throat, which is retropharyngeal. These can be very serious, even life-threatening, through sepsis or airway obstruction. Symptoms might include severe sore throat, difficulty swallowing, or specific voice changes. Let's talk for a minute about your guts. A lot of us have had gastroenteritis or a stomach flu before. Often caused by viruses, they can present with nausea, vomiting, diarrhea, and they usually resolve with gentle hydration and some symptomatic treatment. Bacterial colitis is something entirely different, especially from pathogens like Shigella or E. coli. These can cause bloody diarrhea, severe abdominal pain, and systemic symptoms, the whole fever, rigors, altered mental status. These require specific antibiotics and monitoring for complications like kidney or blood disorders that can follow. Failing to ask the right questions or misjudging the severity here could lead to serious consequences. Separating simple from serious infections ultimately becomes easy as they diverge more and more. But almost all serious infections start with something simple. The question is, how soon can a clinician catch them? Right? It's something to be said about the reasonableness of when a physician should be worried and when they should not be. Separating simple from serious infections ultimately becomes easy as they diverge more and more. But almost all serious infections start as something simple. The question is, how soon can a clinician catch them? Physicians have to do good histories, good physicals, consider risk factors in order to identify who is at risk and what really is going on with respect to the infection. Here are a few ways that a physician could catch a serious infection sooner. Firstly, vital signs. Temperature, heart rate, blood pressure, respiratory rate, oxygen saturation. Abnormal vital signs are a red flag. Clinicians must be able to explain why vitals like fever and how high it is. How high is the heart rate or the tachycardia? Why are they hypertensive or hypotensive? Why are these things abnormal in the context of infection? Ignoring these can delay critical interventions. Next, risk factors. Depending on the serious infection you should be worried about, there are different risk factors that increase the chances. Does the patient have the comorbidities that bring those things to bear, like diabetes? Are they immunocompromised? Do they have chronic diseases that predispose to severe infections or even rapid decompensation? Are they young and healthy? Sure. That could lead to certain risk factors for particular disease states as well. Overlooking these can lead to underestimating an infection's potential severity. Another one that's critical is the period of observation. If someone presents with negative prognostic features, things that make us concerned, even if a department is busy, that's no reason to rush them out the door. Take the time, do the investigations, watch the patient, get a sense of how they're fluctuating, how they're changing. Are they getting up easily and comfortably to use the washroom? Are they asking for something to eat? Do they keep requesting more symptom management? These are big clues, and where good nursing care comes along to help with the diagnosis. Patients can wait a long time to see doctors. They don't want to abuse the clinicians or take up space. If they are told, "Don't worry, you're fine," they will be much less likely to return even if something changes. They feel bad or guilty about tying up resources. Premature discharge and inadequate follow-up can result in missed opportunities to advance care as it's needed. Managing serious bacterial infections requires not just medical knowledge, but also the vigilance, thoroughness, and a proactive approach to care. As we close, remember, advocating for your health includes understanding these nuances. As both a physician and an attorney, my role is not only to heal, but also to ensure that the practice of medicine adheres to the proper standards of care, safeguarding patient outcomes and advancing trust in our medical system. If you have concerns, visit my website at acuitymedicallaw.com, and thanks for tuning in this week.